There are certain words that immediately change the atmosphere in a room. Meningitis is one of them. This week, headlines reported again the tragic death of a student linked to a cluster of meningitis cases involving schools in Oxfordshire and Reading. And two additional pupils from different schools are currently receiving treatment. And while public health teams are working to identify close contacts, other teams are helping to provide precautionary antibiotics. And almost instantly, social media did what social media does during moments of uncertainty. It speculated, it fear-mongered, started making accusations. And of course, conspiracy theories abound. So on this episode of In Plain Sight, we're going to step away from the panic and always back towards the evidence. Meningitis. I touched on this in the last podcast about the Kent outbreak, but meningitis, how is it actually spread? Why are health officials responding the way they are? And why is this not just a medical story, but a major infection prevention and control issue, which is my bread and butter? Those questions are important because somewhere between the fear and the facts is where the real story usually lives. So, what's happened? Well, according to statements from the UKHSA, one student from Henley College has sadly passed away, while two other pupils from schools in Reading are being treated for meningitis. Now, the UKHSA has stated that close contacts have been offered antibiotics, public health advice has been issued, and most importantly, testing suggests that this strain is not the same strain linked to the outbreak in Kent and Dorset only a few months ago. Now, officials have also stated that the wider public risk remains low, which is reasonable. Meningococcal disease does not spread easily, which is very true. And large outbreaks remain relatively uncommon. Again, that is factually accurate. And all of those distinctions matter because one of the problems during any high-profile infectious disease event like this is that people begin connecting dots that are unrelated and they form them into one giant narrative. But epidemiology does not work like internet speculation does. Clusters can occur independently, different strains do exist, and public health investigations are based on laboratory analysis, not on viral posts on the internet from the John Campbells, etc., etc. So what is meningitis really? Well, simply put, meningitis is inflammation of the membranes surrounding the brain and spinal cord. And it can be caused by a number of things. It can be caused by viruses, bacteria, fungi, and rarely other conditions. And it can become a secondary factor of those other conditions. The form causing the greatest concern in the recent UK cases is bacterial meningococcal disease, which is notably called Men-B, which you might have seen it referred to in the news. And this is where IPC becomes critically important because meningococcal disease can progress frighteningly quickly. My sister had meningitis twice when she was younger. Now, symptoms can include the typical things that we learn of growing up: fever, headaches, vomiting, sensitivity to light, confusion, a stiff neck. Sometimes you can have cold hands and feet, muscle pain, which is the viral associated aspect of it, and a rash that doesn't blanch under pressure. That's one of the most notable things as a parent you get told to look out for your children. And one of the challenges from an IPC perspective is that early symptoms can resemble flu, a viral illness, even severe exhaustion. And that means delays do happen. And with meningococcal disease, hours matter. Now, the infection prevention and control perspective is important because this story is not only about tragic illness, it's also about how infection prevention systems activate in real time. Because what you're seeing right now is infection prevention and control in action in a community setting. Rapid case identification, contact tracing, prophylactic antibiotics, risk assessment, and communication management. You've also got laboratory typing and public reassurance, all happening simultaneously. And in healthcare, IPC is often invisible when it works well. We have dozens and dozens of outbreaks all the time, but people rarely notice. They rarely notice the outbreaks that didn't happen because systems interrupted transmission early. Infection control nurses interrupted it. The UKSHA, public health. The response reflects a classic public health containment approach. Identify close contacts, reduce transmission opportunities, monitor for further cases, and communicate proportionally. And proportionate communication matters enormously. You could argue it is one of the most important factors because panic itself creates harm. You only have to look already at social media and YouTube videos coming out in the last 24 hours. And we saw this repeatedly during COVID. Misinformation spreads faster than any pathogen ever could, and it's more dangerous. Now, addressing some of the conspiracies, inevitably, some online discussions are already attempting to link these cases to unsupported theories. As always, it's the vaccines, it's a government cover-up, there's a secret outbreak being planned by a cabal, or some nonsensical broader societal conspiracies. At this point, there is no evidence supporting claims that these cases of meningitis or any cases of meningitis are part of some hidden agenda or manufactured event. None, nil, nada. And it's important to say that clearly. And it's also important to emphasize what we do know as fact. Meningococcal disease has existed for decades. Outbreaks have historically occurred in schools, universities, military settings, shared accommodations. Why? Because it's a close contact environment which increases the transmission risk. And teenagers and young adults are the highest risk group. That is not a surprise. This is established infectious disease epidemiology. It's not speculation. And one of the dangers of this conspiracy culture that social media and YouTube perpetuates is it often replaces practical action with emotional certainty. But infection prevention control depends on practical action, recognizing symptoms, seeking urgent care, encouraging people to seek urgent care if they're unsure, follow antibiotic guidance, support your vaccination programs where appropriate, and ultimately try and reduce stigma and panic. Those things are what protects communities. So why young people are often affected? Well, this is another important point that's often lost in all the chatter online. Meningococcal bacteria can live harmlessly in the back of the throat in many people without causing illness. It's asymptomatic carriage. And most carriers themselves never become ill. It's a bit like group A strep, a bit like E. coli. We carry it in our bodies. It will necessarily never make us ill. But in some individuals, the bacteria invades the bloodstream or the nervous system. Transmission is usually linked to prolonged close contact, as we've mentioned, which means coughing, kissing, can be shared drinks, sharing vapes, cigarettes. It's probably vapes more than cigarettes now, but you get the gist. Or just living closely together. And that's why universities and schools and halls of residence and essentially crowded social settings often appear in outbreaks. But importantly, this is not spread like the measles, for example. Public health officials have repeatedly stressed that meningococcal disease does not spread easily through casual contact, and it doesn't. So again, that nuance matters importantly. It matters absolutely. So next, let's discuss vaccines, reality, and limitations. Vaccines are part of the story. When are they not when it comes to infections? But not in the way societal media often frames them. The UK already uses meningococcal vaccine programs, including the Men-A-C-W-Y and Men-B vaccines in specific age groups. They've been around for a long time. But no vaccine covers every strain perfectly, as no vaccine covers every strain of any infection perfectly. Protection can vary from person to person, and outbreaks can still occur even in vaccinated populations. That is not evidence that vaccines don't work. It's evidence that infectious disease biology works. Infection prevention and control is never one single intervention. It's layers upon layers of multidisciplinary and multimodal approaches. Vaccination, surveillance, rapid diagnosis, antibiotics, communication, isolation where appropriate, and public awareness, importantly. Real world infection control is rarely about absolutes. It's about reducing risk intelligently. A serious infectious disease story breaks. Society faces the same choices: fear or understanding. Those are pretty much the only two. Everything else gets lost in between. And out of the two of them, understanding is harder. Acceptance of understanding is even harder because it requires patience, it requires evidence, it requires humility. And sometimes it's accepting that uncertainty exists before all the answers arrive. The death of a young person, the death of any person due to an infection is genuinely tragic. The concern felt by the families is understandable. But the answer is not panic and unsupported claims. It's vigilance. It's good public health. It's good infection prevention and control. And it's good evidence-led communication. Because in a world increasingly driven by noise, and especially driven by noise on social media, sometimes the most important thing we can do is look for the answer that's hiding in plain sight. It's important to add that this is where the recent Kent outbreak becomes incredibly important for context. What is happening now in Oxfordshire and Berkshire is not occurring in isolation because earlier this year, Kent experienced one of the most serious meningococcal outbreaks in recent UK history. And as you may remember, the outbreak centred around Canterbury and involved students from the University of Kent and several local sixth forms. And at its height, there were more than 20 confirmed or linked cases that were investigated. Multiple young people required hospital treatment, and tragically, 2 deaths were confirmed. The UKHSA identified the strain involved as meningococcal group B, Men B, which we mentioned earlier, with several cases linked epidemiologically to shared social settings and close contact environments. The main areas being nightlife venues, nightclubs, and student accommodation. And this is a crucial IPC lesson. Infectious diseases do not care where the transmission occurs. They don't care if it happens on a hospital ward, in a nightclub, in a university hallway, or in a classroom, or in a dorm room. Close human contact is what matters. It doesn't matter where it occurs. And one of the reasons the Kent outbreak received such significant attention was because of the speed of the progression and the concentration of the cases within interconnected student populations. Now, the UKSHA responded with a mass antibiotic distribution, which you'll have probably heard and seen on the news. There was targeted vaccination campaigns, which are ongoing. There was some enhanced surveillance. There were educational messages and ongoing epidemiological investigation, which feeds into this current situation. Importantly, though, and this matters enormously for public understanding, the UKSHA has already stated that the newer Oxfordshire and Reading associated cases appear to involve a different strain from the Kent outbreak. A different strain from the Kent outbreak. And that distinction immediately weakens many of the online claims already suggesting that there's some sort of hidden epidemic occurring. It just breaks that apart immediately. This is what real epidemiology often looks like. You've got multiple localized clusters, you've got different strain types, different transmission chains, and rapid public health investigation trying to determine whether links do or don't exist. Because not every outbreak is connected, even if it's the same infection. Not every rise in cases means societal collapse. And not every tragic event is conspiracy of evidence. And it's inhumane to weaponize it as something it isn't. Sometimes infectious disease patterns are exactly what microbiologists and public health teams would statistically expect to see, what I would expect to see. Sporadic outbreaks in higher risk societal groups where close contact increases transmission opportunity. Now, the Kent outbreak also explains why health agencies are reacting so quickly now. They did get some criticism that did or didn't they act quickly in the first place. One of the realities of IPC and public health is that previous outbreaks shape future responses because you learn by experience. You learn from what worked and what didn't. Now, after Kent, awareness increased, just tacitly anyway. Clinicians became more alert to symptoms. Schools and university improved their communication pathways. There was more advertising about symptoms to look for. And the UKSHA refined their rapid response measures around student populations. This is an example of a system actually working. Public health systems learn, and they should learn. Surveillance improves, and responses become faster. So while online commentary often portrays official responses as either an overreaction, too slow, it's a cover up, the reality is usually far less dramatic and far more practical. Identify the risk early, interrupt the chain of infection, interrupt transmission, protect close contacts, and prevent isolated clusters from becoming larger outbreaks. That is infection prevention and control at population level. Quiet, unseen, but absolutely essential.